Hello there, welcome to ShineTech's YouTube channel. In this video I'm going to talk about membranous nephropathy under the topic pathology of the kidney and its collecting system. So the diseases which affect the kidney are divided into those which affect the glomerulus and those which affect the kidney tubules, including those which affect the blood vessels of the kidney nephron. So the diseases which affect the glomerulus are divided into two. We have those which are called primary glomerular diseases, and we also have those which are called glomerulopathies secondary to systemic diseases. We started by looking at primary glomerular diseases, in which we looked at minimal change disease, focal segmental glomerulosclerosis, and we are now going to look at membranous nephropathy. So for anything to be filtered in the glomerulus of the kidney, it has to pass through three layers, which are the endothelial cell layer, followed by glomerular basement membrane, and the slits, which are formed by the foot processes of the podocytes there. So in minimal change disease, we said we have factors or cytokines which are produced by T cells, and also we had slender factors which are produced by macrophages, and those factors led to podocyte infacement of the podocytes, and that caused what we call proteinuria, that is protein in the urine. Okay, and in focal segmental glomerulosclerosis, we said we had an injury in the podocyte, and that injury led to hyalinosis, that is deposition of hyaline in the basement membrane of the glomerulus, and the overall result was sclerosis, hardening of the basement membrane, and also we had infacement of the podocyte foot processes. Okay, so the differences between the two, minimal change disease and focal segmental glomerulosclerosis, are in this table, so you can pause and review. For now, in this video, we are going to look at membranous nephropathy. So membranous nephropathy is characterized by subepithelial immunoglobulins containing deposit along the GBM, that is the glomerular basement membrane. So we have these immunoglobulins, okay, which forms deposits in the glomerular basement membrane. Okay, so that is the main characteristic feature of membranous nephropathy. So in the early disease, the glomeruli may appear normal by the light microscope. So when you observe this under a light microscope, the glomeruli may appear to be normal. Okay, but advanced cases of membranous nephropathy will show diffuse thickening of the capillary wall. So the capillary walls will thicken. Okay, and this kind of a condition is mostly found in adults between the age of 30 to 60 years. Okay, and it follows an indolent and slowly progression course. So it follows a silent and very slow progression course. Okay, and it is up to 80% of cases of this condition, membranous nephropathy, are primary. Okay, are primary and are caused by antibodies, as we have already said, immunoglobulins, which form complexes. Okay, so these antibodies are against the podocyte antigen. They are against the podocyte antigens. So we have said that 80% are primary, meaning they do not result from another condition. They are primary. But we also have the remaining cases, which is 20%. So in the 20%, the condition occurs secondary to other conditions, such as 1, infections, So infections such as chronic hepatitis B, we also have syphilis, we also have schistosomiasis, and we also have malaria. So these infections can also lead to membranous nephropathy. Then apart from that, we also have malignant neoplasms, particularly we are talking about carcinomas of the lung and colony. We also have melanoma. Okay, so these also can lead to membranous nephropathy. Apart from this, we also have autoimmune diseases, and we have drugs such as penicillamine and captopril, and non-steroidal anti-inflammatory agents. So these drugs, the NSAIDs, can also cause membranous nephropathy. So now let's move on to pathogenesis. We talk about how these diseases takes place. Okay, so membranous nephropathy is a form of chronic immune complex glomerulonephritis. Okay, so it is a chronic condition which is induced by formation of immune complexes. Okay, so these immune complexes are formed by antibodies reacting in situ to endogenous planted glomerular antigens. So we have antibodies reacting with antigens, and they will form complexes, forming immune complexes. So these antibodies are against what are the antigens in the podocytes. Okay, the antigen which is phospholipase A2 receptor. So phospholipase A2 receptor, which is in the podocytes, reacts with the antibodies which are formed by our immune system. Okay, and this is not an established causative. Okay, so it is not confirmed to be the causative of this disease, but antibodies and antigens such as phospholipase A2 receptor, they react and form an immune complex. Okay, so the formation of that subepithelial immune deposit, that complex, will lead to complement activation. We know that the antibodies, the Fc portion of the antibody, can activate the complement system, more especially the classical complement pathway, and that will lead to formation of the membrane attack complex. So this membrane attack complex will be formed, and that will also lead to destruction of the membrane. Okay, destruction of formation of complexes in the basement membrane of the glomerulus. Okay, so this in turn will cause podocyte injury and proteinuria. We know that if we have injury to the podocytes, what will follow is the loss of proteins in urine. So that is the pathogenesis of membranous nephropathy. Moving on to the morphology. Okay, so what will be observed here is that the main histologic feature of membranous nephropathy is diffuse thickening of the capillary wall. So the capillary wall will be thickened. Okay, that is because of these subepithelial deposits. Subepithelial deposit will cause thickening of the capillary wall. And then apart from that, we are going to have effacement of food processes of the podocytes. The podocytes food processes will be destroyed, and later in the disease we are going to have incorporated deposits. Okay, those complexes will be deposited, okay, in the GBM, that is in the glomerular basement membrane. So once they are deposited, they are going to be covered by spike-like. They are going to be covered by spike-like the spikes of the GBM. Okay, so those spikes will cover the deposits. They are going to be incorporated, and they are going to be covered. Once they are covered, then they can be broken down. They can be broken down and eventually disappear. So once they disappear, they are going to leave cavities within the GBM, within the glomerular basement membrane. Okay, so we have cavities formed in the GBM. That is also a morphologic feature. Then apart from that, continued deposition of basement membrane matrix will lead to thickening of basement membranes. Okay, so once those complex are being deposited in the basement membrane matrix, the basement membrane matrix will do what? Will thicken. Okay, and the glomeruli may also become sclerosed. Okay, it may harden due to those depositions. And now in the immunofluorescence microscope, what will be seen is the deposit of immunoglobulins. Since we have immunoglobulins there, so using this microscope they will be observed. Okay, and also apart from immunoglobulins, we're going to observe the complement proteins along the glomerular basement membrane. Okay, so in summary, the morphologic features which are observed in membranous nephropathy, we have the diffuse thickening of the capillary wall, we have effacement of podocyte food processes, we have cavities formed within the glomerular basement membrane, we have thickening of basement membrane due to deposition of those complexes into the GBM, and then we also have cavities which are going to be formed due to breaking down of those complexes which are incorporated in the GBM are going to form cavities. So cavities will be formed. Okay, so that is all about the morphology. Now clinical features. So in most cases of this condition are sudden in onset, and they present with full brown nephrotic syndrome without antecedent illness. Okay, so without any secondary illness, we are going to observe full brown nephrotic syndrome. Then apart from that, we have lesser degree of proteinuria. So the protein which is lost is lesser. Why? Because the layer is going to thicken. Okay, we mentioned in the morphologic features that we also have what we call sclerosis may also happen there due to thickening of the GBM. So lesser degrees of proteinuria, and this proteinuria is non-selective. So it is non-selective, that is, we have more than one type of proteins which are lost in the urine. Okay, so apart from that, when it comes to therapy response to corticosteroid, most patients fail to respond to corticosteroid therapy, and proteinuria is going to persist in greater than 60% of patients, and only about 40% progress to renal failure. So about 40% are going to progress to renal failure over the period of 2 to 20 years, and an additional 10 to 30% of cases have a more benign cause with partial or complete remission of proteinuria. So we can have partial loss of proteins, or we may have no proteins which are lost due to that thickening. Okay, so thank you so much for watching. Don't forget to like, subscribe, and leave your comment in the comment section.